Now you see my gratefulness. Oh my God. So, and also my worry that I had to write a story. And here you can see my son. That is what he is doing. And there you can see where we're going to later on today. So, the preparation, I had to think because, like I said, the story has to fit the audience. And when I was thinking about the audience, I thought, I'm sitting here in front of the psychedelic community. And you already know a lot of this, so what can I teach you? So I was thinking, and I think we have to think about our role in this whole story. And it's up to us to spread our knowledge, because every time I speak to the psychedelic community, it's actually preaching to the choir, they call it, huh? And it would be lovely if we have a discussion about what can we do to spread the knowledge, so that everybody else who is not here today, so the general population who is not into this whole psychedelic medicine field, how can we learn them about what we know, so that in the end everybody is informed about psychedelics. And that will be the main topic of my presentation today, and I hope that it will be something you enjoy. So I think, and I also think that Jan emphasized it, it is all about the perspective people have. And I will tell you a bit more about the perspective I had when I started. It's about the perspective, and it's about communication, correct communication. And it's all in our hands. So, when I started in 2003, it was actually in the climate that Jan already sketched. People were talking about that MDMA or ecstasy, and it's really important that if we talk to people, we keep these two separated. So we're not going to give ecstasy to patients, we're going to give MDMA to patients. But in this literature, you see that they use both next to each other. So there was a lot to do about people using ecstasy, that they suffer from memory impairment. It was, this publication was from a bit earlier from when I started, but it was still this climate. And we started, the study started in the second MDMA study we did. It started in 2002, and we were interested to investigate whether there is a causal relationship between MDMA and memory. And that were the data that Jan showed. But also in that same year that we were doing this study, this publication came out. So that was shocking, because they said, we've tested MDMA and we have shown that it's very highly neurotoxic for the dopaminergic system, which was something odd because MDMA mostly works on the serotonergic system. But then later that year, that came out. The people had to retract their publication because it appeared not MDMA that they had given, but it was actually MDA, and they had to go through a large effort to find it out, but probably the vials were mixed up. So, but this happens in science too, and I think that it's good that they owned this, that they also came out, because it was a very important publication and an important journal. But still, and they also said, they owned it. And then I also have to tell you about my heroes back then, and this is also very important in the story of the perspective. So also back then, you had naturalistic studies with MDMA. So you see that on the left-hand side. You had Valerie Kern, who's now very famous for her cannabis research, and you had Andy Parrott. And what did they do? They went to nightclubs and they tested people who ingested MDMA or ecstasy. And then they tested them in the lab to see whether their cognition was okay, whether their mood was okay. And from these publications, we know about the midweek dip, which is still something that is under debate, and people attribute it to taking a lot of MDMA, stacking it, using it in combination with alcohol, but also not taking care of yourself, not sleeping well. So they say it's the midweek dip can be attributed to that. And then on the other side, and this has to also be has to be acknowledged that we already had controlled studies in the 90s. And I think, yeah, we have Charles Grob, but I do think that, and I like to mention him because I see Frans Vollenweider of one of the pioneers in this research. He did trials with MDMA, he did trials with psilocybin. So he's very important, and also, if you do not know the older literature, please go back and read it. But back to the left-hand side of the screen, and there we see parrots. Somebody I really, it was kind of, I idolized him, and during one of my first conferences, I had a poster presentation about my findings. I went together with Jan to that conference. And Parrot came and visited my poster, and I was so starstruck. But that changed. So actually, it changed because of a publication in 2013. And there was a lot to do about this publication. I received an email from somebody in this field saying, "Have you seen that?" So he said he made a review about the research that has been made in the past 25 years back then. And he said MDMA, ecstasy, is so damaging, far more damaging than we could ever imagine. And he was on a mission, I think. And then the field decided to respond. And the field, I mean Rick Dublin and his team, put together a reply. And that is also nice in science that you can do that. If you do not agree, you can always write a paper saying that you do not agree. But, and it is actually, you also have to see that in the context. So in the early 2000s, you had this MDMA is damaging, but then we got traction, and in 2010, you had this change, this shift in the field, and people were focusing on the pro-social effects. So this is actually a crucial time that this review came out, because we were all more focusing on the positive effects of MDMA and also in therapy. And then Parrot comes and says, wow, this is such a damaging drug, people should not use it. And I think it was good that Rick and his team put together a paper. But then, of course, Parrot could not lag behind. And he said, look, I went through all the arguments that Dublin and his colleagues gave, and they're not right, I'm right. And that is when you're looking into perspectives of people. Was Dublin right? Yes, he was. Was Parrot right? In a sense, he was too. You can read his article again. But what they do forget is, and this is also something else, what he forgets is that we're talking about, on the one hand side, recreational use, which is uncontrolled, and on the other hand side, you're talking about controlled use in a therapeutic setting. This is an excerpt from the article, the second article he wrote, and he said that there was a person who read about MDMA becoming licensed, and he said, well, if it becomes licensed, then it's safe to use, so I will use it recreationally. That is the wrong type of thinking, and I think we have to bring that across people, because whenever we give a lecture, people think, wow, MDMA is so positive and it can have positive effects for me. But then you have to see this in a context. And then here I also have written down that you should always, and I told it in the beginning, you should always tell people that MDMA is not the same as ecstasy. So what I'm going to talk about today is whether MDMA can have a therapeutic potential, also a bit about how it works, whether it's safe, and the indications. But it will not take too long. So I think Jan also already told it. What can you do to create knowledge? You have different sources of knowledge. You have these case studies, which are also very important, telling you about what happens when a person takes MDMA. You have animal studies, also important, because you can do more in animals than you can do in humans. But the most important, no, I cannot. All types of research are important. One important type of research is the placebo-controlled research, in which then you give a sample of people, MDMA, and in this example, MDMA on the one side and placebo on the other side. You assess the effects on cognition, prosocial behavior, subjective effects, and then you compare it. If the effects are larger under MDMA compared to placebo, you know that there is a causal relationship because MDMA has caused the effect. What I always say is we have this large amount of substances, and up to us is we have the task to come up with, to understand the effect profile of all these substances, and then link it to the disorders there are. So it is about, and I will show you that in the example. For example, another example is, it's not in the presentation, if you see, and it has been shown that psilocybin enhances cognitive flexibility, and you think about disorders that are lacking cognitive flexibility, or cognitive, those who have cognitive rigidity, it might be good for that disorder, and that is the case for depression. So you have a rationale why you could use it in that disorder. And then you should also have the discussion with people, is it really needed psychedelic medicine? Because we have all these conventional treatments for years. And then I think it's up to us to really think about, what does conventional treatment do? Is it good in terms of outcome? But also listen to the patient, because you hear that people are not satisfied with their treatment or have too many side effects. So listen to your patient and think about whether another treatment could be more beneficial. So this is an article from way back, and it's also worth reading it if you haven't seen it, but it was the plan of MAPS to have MDMA-assisted psychotherapy as a treatment for PTSD. And actually already in this article, Rick Doblin explains why it could help. So back to my reasoning, is MDMA-assisted psychotherapy and PTSD, is it a match? Let's have a look at the symptoms. So people with PTSD re-experience the event, try to avoid painful situations or emotions, show emotional numbing, are also hyper-aroused and experience a lot of other problems. What we also see when we look into the literature is these barriers, these problems, these challenges, that people with PTSD experience a negative attitude towards themselves, and that is why their help seeking diminishes. They also because they want to avoid their trauma and want to avoid talking about it, it decreases their help seeking. So now it's up to us to figure out whether MDMA could help with these problems. So, spoiler alert, yeah, you already know it, you've read it, MDMA works in the treatment of PTSD. But it's then, like I said, up to us to understand how it works. And I'm perhaps too fast. It works, yes, but it will not work for everybody, and it will not last that long for everybody. So there are still question marks. So if we look at PTSD, we have certain aspects. I've also showed you that on a couple of slides ago, but now I want to focus on certain areas. We know that people with PTSD have problems in emotion recognition. They have, for example, problems in seeing happiness, recognizing happiness. And I put between brackets also next generation. It actually disturbed me to learn that the next generation of PTSD patients have problems in emotion recognition. So it's really pivotal that people are helped so that the next generation does not suffer from that. I don't know exactly how it works. Your body also has a memory, and it can go long into generations. So if you have a look at emotional empathy, so feeling what the other person feels or being aroused when you see another person in distress or being happy, you also know that in PTSD that is disturbed. Also their emotional memory is disturbed. They memorize more negative events, and their mood levels are also disturbed. So let's have a look at MDMA. The text is very small, but I tried to fit it in the same boxes. So actually, the bottom line is, in all these domains that I've shown you, we see that MDMA has effects. That, for example, if you show them pictures of people who are angry, the expression of the emotion has to be more intense or clear for people to recognize it under the influence of MDMA. And I will tell you why that is good in the next slide. Also, when they see happy expressions, their frowns go down, which is also a good sign. MDMA, and Jan already told it, emotional empathy goes up, but we've also shown that if you present them with disturbing fragments, auditory fragments, their arousal level goes down. Emotional memory, it has been shown that people are more able to recall or give more positive ratings to positive memories, and the negativity of ratings of negative events goes down, which is also very important because they remember, people with PTSD remember more negative events. We've also shown that positive mood goes up, but also that anxiety and confusion goes up when you ingested MDMA. But we also know that if you have support, that this anxiety can be dampened. So back to what I started off with, people with PTSD have a range of symptoms, and MDMA can help with a range of these things. We saw on the one hand that people try to avoid it, their trauma, and that they feel emotional numbing. We see that MDMA helps with, it amplifies the mood state, so no emotional numbing. And we also see that they're not trying to avoid negative things, that they are less aroused by these things. To give a couple of examples. Why could it help in these barriers? Because it has also been shown, yeah, I did not show it on the slide, but that social interaction improves, and they see their partner, or the person they're interacting with, as more caring. This is very important in a therapeutic context. I have to say, all these studies that I've shown are done in healthy volunteers, so not in people with PTSD, but it shows the effect profile of MDMA and that it could help. This is another one, and why did I put this on a slide? Because I think, just because of the year. It was published in 2009, and it already stated, well, MDMA can help because it increases oxytocin levels. We've shown that afterwards too. And that helps with bonding, that helps with the therapeutic alliance. It decreases amygdala activity, and it also helps with the fear extinction, which is all important in PTSD. But you can read about it, and here is also another overview. I just put it on the slide so that you can have a look at it. It's more detailed on a biological level why MDMA could help in PTSD. But in this whole story, I've been talking a lot of about MDMA, but you should not forget about, and now I'm looking at two people who I know and who are in therapy. No, not personally, who are therapists. Sorry, I have to say it differently. MDMA does not do the trick on its own. It has to be accompanied by therapy, and that is a very important message we have to give to people, to the general population, if we talk about it. We have to show them or talk to them about a 3-stage model. It always has to be like this. So you start off with your preparatory session in which you get to know your patient, you do your psychological screening, your physical screening, and start to build a relationship. Then, when the participant or the patient is totally ready, you do the drug sessions. Now in the MDMA model, it are 2 to 3 sessions with, how do you call it, a low dose. You can start off with 80 milligrams. You can dose then up, you can give a booster, half a dose. So you have to think about the range is in between 80 and 180 milligrams of MDMA. A session takes a whole day, so when the participant ingests MDMA, and there are always 2 therapists next to the patient, which is important also because it is a long day. I think you cannot do that alone as a therapist. It is also a bit of control over the situation, I think, that everything happens according to rules you agree to. And then we should not forget about, it's not only giving MDMA to a patient and then that it's finished. It's also about the integration sessions that follow. It's about talking about the experience and how they can integrate it into their lives. So when you talk to people, make sure that you always say MDMA-assisted psychotherapy, and then the 3 stages. And then this is the last part of my presentation. Whenever I give a presentation, people say, wow, you're so positive about MDMA. And the general population has then these questions because in the media you see reports of deaths of people after they took ecstasy. So we're going to have a look at, can you die if you take MDMA? Can you become addicted? And is it damaging to your brain? It are all valid questions if you're going to give something, a substance, to a person. So can it kill you? I have 3 cases. So the first case is a relatively young case. A teenager died after taking ecstasy. It's from 1 month ago. And in the next slide, we will go into more detail. So that's shocking. And I also think, because we're now running this trial with MDMA-assisted psychotherapy, I think if patients who are to be enrolled in the trial read this, they have to be scared, right? Because they enter therapy and they could die if they believe this article. Another case report, and that is why I always have a look at case reports that are being published. Here, a description of a woman who took MDMA, but before she took MDMA, she already took a lot of pills and she also consumed alcohol. She became deliric, she hurted herself, and after I think she already died at home. She had a very high temperature. And then the third case, the person did not die, but used a lot of ecstasy, ended up in the hospital. And they first tried to, I don't know what they first tried to give him, but then they gave a diuretic, and then the patient peed, 6 liters of water came out. So that's a lot, and I will. So if you, whatever you do, or also it has been linked to marathon runners, if they drink too much, you can die because you dilute your blood and your brain can swell up. So it's not only linked to ecstasy. So the message will be, do not drink too much water. If you drink, use isotonic substances. So in the first case, that was, thank God, that was also in the article, but people, the general population cannot think about this statement. So they were with a group of 6 people and they bought 7 grams of ecstasy, and they split that up. So that is already a lot. In therapy, you receive between 80 and 180 milligrams of MDMA. So if you read this, they took 1 gram each or more. So it's in the dose, do not take too much. In the second case, it was about, and that is the importance, you see something in the newspaper, perspective, but then you see this case report of a coroner, and this person showed that, so not only did she take ecstasy, alcohol, and pills, but she also had a genetic predisposition that led to her hyperthermia. So it's not it is just the combination of events and her biological predisposition that caused her to die. And then the third case, I already explained it, too much water will kill you. So when you talk to people, it is important to make them aware of, you can have polypharmacy, but in a therapeutic setting, you will not have polypharmacy, you will only give MDMA. And you will give a known quantity of MDMA. Here, the people just use ecstasy and you don't know how much is in there. And we also know from the reports that there are a lot of pills that are high dosed now. Also important is to disentangle this. This is in an uncontrolled context, and it's something very different from therapy. We know that, huh? But it's very important that you state that explicitly when talking to people. And here, this is also an interesting link. I think I only found it from the UK. They also put it into perspective. They say, look, there are people who die from ecstasy use, but if you compare it to other drugs like heroin or alcohol or whatever, it's much lower. So also putting into perspective that people die from other things too. David Nutt already did it with his article about ecstasy when he compared using ecstasy to horseback riding, which was more damaging to you. So is it addictive? Here I have a part of the paper you see, and they say, what I also always say, it's not physically addictive, but it can be psychologically addictive. And if you look, I have been looking for this presentation to find numbers, but I didn't find them again. We know that there are people with a primary indication in healthcare for their ecstasy dependency. So it can happen. But then again, you have to say, look, if we're going to give this in therapy, people have a specific intention to get rid of to be healed from their PTSD. And it will also be in a controlled setting, and they will receive it 2 to 3 times. So it will not be DIY. And Jan already showed it, is it damaging to your brain? So indeed, and here you don't see my animation, yeah, I hope you see my animation. So what they did is indeed give MDMA twice a day for 4 times in a row, 5 milligrams per kilogram. They gave that to this animal, to a group of animals. So they decapitated some animals before they gave them MDMA, that is in the A panel. And then you see here, after this week of MDMA dosing, and these are the serotonin neurons you see. So after dosing for a long time, a whole week, they see that the innervation is, that there is neurotoxicity in the brain. But I also think it's very important that they kept a number of these squirrel monkeys and they decapitated them after 7 years. And what you see is this. So you see regrowth of neurons. So it's not detrimental if you take it, but you also have to tell people, if they would read such a publication or if you see it in the media, have a look at the methods. How much did these squirrel monkeys get? You do not give that to people. You do not give it intravenously, you do not give this high dose, and you do not give it twice daily for 4 days. So it's again putting it into perspective for people. And then it's a question, but I'm going to round up. It's a question about, can you translate animal research to human research? So the question is, when you talk to people about therapy, they ask you, when will it be on the market? And I know that Rick Doblin had said years ago, it will be on the market in 2021. Huh. It did not happen because, yeah, also Corona came in between, I think. But for now, I can tell you that in the US, they are in phase 3. In Europe, we're still in phase 1, going to phase 3. After that has been completed and they have approval by the FDA and the EMA, it will come on the market. But then again, we have the next problem. We need therapists who are able to give this. So I think this week a journalist asked me, well, what do you think? When will these psychedelics and MDMA be reality? I said, I think it will still last 10 years, and then when everybody is into the story, 20 years. But I think this is reality if we do not start informing people about this. Here I also put some indications for MDMA-assisted psychotherapy. So they have shown that it can help in PTSD. They have also now a new study out in their PTSD patients. They looked at eating disorders, which MDMA can also be helpful for. It helps in social anxiety disorder in people with autistic spectrum disorder. It helps in alcoholism. I know that there will be a trial in depression. So it is, again, looking at the effect profile of MDMA and trying to match that to symptoms. Yeah, this is very important. It's not about pushing everything what we've learned about therapies away and then here you have psychedelic medicine. That will not be the case. And I think this also has to be clear to people. You just have your conventional treatments, but you also will have psychedelic medicine integrated into that. And we still have question marks because how should the therapy look like? Will we combine MDMA with other substances like LSD, candy flipping to... yeah, no, but I think I had discussions with people about this and we don't know how it will look like or whether we give psilocybin first and then proceed with MDMA or not in combination, but then you know what I mean. And there's also a question about how many sessions will a person need, because now it's standard, you will receive 2 or 3 sessions, but it can be that patients in real life will need more treatment. And you also know from patients who were in a trial who could need another trial, but it's not available yet, and it's frustrating. And then also from a cost perspective, should it be individual treatment or group treatment? In psychedelic medicine, they're also now doing some trials with group treatment. And it also has to be clear that it's not for everybody. It will not be for everybody, but I think it's up to the therapist to decide that. I put this slide especially for you or for the people who are still looking. I heard in the presentation in the opening that, and this is only a limited amount of links. I heard that MIND is doing a good job with courses. I learned about a program in Wisconsin, and I'm looking at Natasha because she came especially from Wisconsin to Maastricht to do something with psychedelic medicine, and now it's over there too in her program. I learned about a program in Vancouver Island. It's also listed there. So there is a lot happening, and it's difficult. I think it's difficult to find out where it's all happening. You can still stay in Maastricht if you're a student. We will also help you. But you can have a look. And it's about, people always ask me, what should I do to pursue a career in psychedelic medicine? But it's really about following your interests and seeing where your good characteristics are. Everything can, we need a multidisciplinary team. We need everybody. So my last slide, I want to thank you for listening, uniMIND, for putting it together, and the team at MAPS, because they have been doing this for 30 years and they're still persevering. Yeah, that's it. And I think questions will be at the end of perhaps the mosaic presentation, or how do you want to do it? Because we're already running late. No,
I think it would be fine if we have a short Q&A now. Do we have questions right away from the audience? And of course I want to, yes, I see the hands going up. So I guess I won't have a chance to ask you, maybe later. And we'll, of course, focus on our audience for the questions first. However, Ramona, where are you? Do we have questions from our online audience? Not yet. Okay, then I can give the mic right to Vlad is preparing another microphone. We'll use this one first. Here, okay. You'll have the first question.
I was just wondering, what's the difference between MDMA and ecstasies?
What the difference is between MDMA and ecstasy? Sorry, normally I put that in my presentation, but I thought I just didn't put it in there. So you have ecstasy, and most people expect MDMA in ecstasy. And that is also the case lately, but there can also be adulterants in the ecstasy, or things you do not expect there. It can be as innocent as caffeine, but it can also be more damaging, like what did I read, can be PCP or something else. So yeah, you don't know.
Okay, next question. Lucas, you'll have to catch the microphone.
Are you ready? Does it work? Yeah. Okay. Oh. All right. So I was wondering, with the classical psychedelics, there's a big movement of kind of tweaking them, finding like the better version of psilocybin or LSD. Do you think there's a need for that as well with MDMA, or is MDMA pretty good as it is? Or do you think what could be tweaked about it, what could be improved about MDMA?
Yeah.
Thank you.
Good question. And I think with MDMA, it's the same as with ketamine. So we always use the, and then I cannot pronounce it, the race mixture. So the RS had the same, so for the people who do not know, you have the chemical structure of MDMA and you have a left turning and a right turning variant of that molecule. And we always use the composition where the both are represented equally. But you also have R-MDMA and S-MDMA, and I think only one paper has investigated, or one study has investigated that in men, and I actually don't remember the results. But when I think about ketamine, they're now promoting S-ketamine. It's on the market as a nasal spray, but we also know that R-ketamine could be more beneficial with less side effects. So indeed, that is something we have to investigate, and I was interested in that. But the problem is, years ago, I really want to see whether there were differences, but you have to find the MDMA that is suitable to use in patients. And back then, I think we only could find one variant. I'm not sure anymore which one. So yes, definitely more research is needed.
Okay, thank you, Kim. Right behind you, who was first? Sorry. We have so many questions. Can you throw it over to that side? Perfect.
Hello. So I have a question. The positive MDMA effects you described, were they only during the session, or also how long did the effects last? And do you think it would have to be like a regular treatment?
Yeah, so the effects I showed were only in healthy participants, and with hindsight you say, why? So we only tested the acute effects, and all the people in the field did. And with the hindsight now, you can think, why didn't you test days after? So we don't know. We did a study in which we tested the second day. I don't think we had effects on mood. People were more fatigued after the first test day. I don't know whether it was specifically to MDMA. I don't even think so. So I don't know how these effects, or how long these effects last. It is something that should be tested. I don't think, and I'm looking at somebody who can also know. It has not been tested yet, right? The enduring effects of MDMA on emotion recognition or emotional empathy. Ah, okay, a recent publication by Rick Doblin, yeah. Yeah, yeah, they started. Yeah. Now you have the opportunity, because you have all these studies who investigated it in a therapeutic context, and they've collected a lot of data which they're now analyzing. So you'll have the answer later, I think.
Okay, we'll have to end the Q&A at this point. I'm sorry.
No,
Kim,
thank you.
Yeah, Kim, thank you for the wonderful presentation.